Hello everyone, I'm Dr. Kaushik Biswas, Senior Consultant Endocrinologist in the city of Kolkata. Today I'll share about a case of type 2 diabetes mellitus of 2 years duration. The patient is 50 years old and he is seeking my attention or consultation for frequent development of hypoglycemia or low blood sugars in the past 2 months. While reviewing his medications, I found he was receiving metformin 2 gram per day and a modern sulfonylurea 2 milligram twice in a day. His laboratory profile revealed HbA1c of 8.2%. Estimated GFR was 88 ml per minute per 1.73 meter square. His lipid profile was within normal limit. His liver function test does not reveal any abnormality. Creatinine was 1.1 milligram per deciliter. He was obese according to his BMI, which was 31 kg per meter square. He was normotensive, the blood pressure being 120 by 70 millimeter of mercury. Now, this is the keeping behind that particular case of type 2 diabetes mellitus, who is on sulfonylurea and other oral drugs having recurrent hypoglycemia. We need to know about the primary objectives of treating type 2 diabetes mellitus, which are the optimization of glycemic control with lesser incidence of hypoglycemia, as well as to provide proper cardiovascular and renal protection, because most of the patients of type 2 diabetes mellitus actually die from cardiovascular diseases. An HbA1c goal for many non-pregnant adults could be less than 7%. On the basis of provider judgment and patient preference, some form of individualization is necessary in targeting HbA1c. In young, relatively comorbid condition-free patient, the A1c level could be as low as 6.5% in some subset of population, and it should be achieved without imposing significant risk of hypoglycemia or other adverse events related to treatment. In the 21st century, we are witnessing type 2 diabetes mellitus as a global pandemic. As far as 2019 data is concerned, India is having 77 million people of type 2 diabetes mellitus, and we popularly call India as the diabetic capital. Indians have a tendency for earlier onset of type 2 diabetes mellitus, having the so-called thin fat Asian Indian phenotype, leading to not only early onset of diabetes, but early onset of cardiovascular disease. And the diabetes is often follow a progressive course. Now, stringent glycemic control as well as other risk factor controls are critically important in people with type 2 diabetes mellitus. Now, sulfonylureas or SU play a pivotal role in the glycemic control in the management of type 2 diabetes mellitus for long years. As a direct extension of their mechanism of action, they are called insulin secretagogues. Sulfonylureas secrete or releases insulin from the beta cell of islets of Langerhans. So that is why hypoglycemia is a major concern for many of the sulfonylureas. However, it is to mention that magnitude and severity of sulfonylurea-induced hypoglycemia range widely across studies. In comparison to older generation sulfonylureas, the newer sulfonylureas are relatively less associated with hypoglycemias. Keeping the adverse events of hypoglycemia or weight gain in mind, what are the other oral antidiabetic agents or injectable antidiabetic agents that are associated with low risk of hypoglycemia or low risk of weight gains? The options are SGLT2 inhibitors such as empagliflozin, dapagliflozin, or artogliflozin or canagliflozin, DPP-4 inhibitors like linagliptin, sitagliptin, and teneligliptins, and thiazolidinediones like pioglitazone and alpha-glucosidase inhibitors. And among the injectable agents which are associated with less incidence of hypoglycemia are GLP-1 receptor analogs. Now, there is a strong rationale for combining a DPP-4 inhibitor and cardiovascular protective class of SGLT2 inhibitor in patients with type 2 diabetes because two drugs exert different but complementary glucose lowering effect. Furthermore, the increase of glucagon levels induced by SGLT2 inhibitor may be blunted by the co-administration of DPP-4 inhibitor. Clinical evidences had shown that SGLT2 inhibitor DPP-4 inhibitor combination is an effective option for management of type 2 diabetes mellitus, providing HbA1c reductions of 1.1% to 1.5% depending on the baseline HbA1c, and they also promote some sort of weight loss, approximately 2 kg, and they have some non-glycemic benefits like prevention of heart failure or cardiovascular benefit, as well as renal protections, which are very, very important in a patient of type 2 diabetes mellitus. The American Diabetic Association recommends the initial combination therapy or early combination therapy when patient is having an HbA1c level more than 1.5 to 2% above target, considering the fact that the absolute effectiveness of almost all oral antidiabetic medications rarely exceeds 1%. So this unique combination of SGLT2 inhibitor and DPP4 inhibitors lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. Now, clinical experience with DPP4 inhibitor and SGLT2 inhibitor combination show that they can be used with a good safety profile and a low risk of adverse events, namely hypoglycemia and weight gain, even when added to metformin, which is particularly very important finding for clinicians. Now, a reduction in the incidence of genital infections with SGLT2 inhibitor was reported when a DPP4 inhibitor was added. We know that SGLT2 inhibitors excrete sugar through urine, and SGLT2 inhibitor can be associated with UTI, mainly genital mycotic infections. But studies have shown that addition of DPP4 inhibitor on top of SGLT2 inhibitor can reduce that infection because of two factors, probably improvement in the glycemic control, and secondly, the DPP4 inhibition, non-specific DPP4 inhibitions over fungi or bacteria or T lymphocytes. So combining these two agents will give much more robust reduction of HbA1c with reasonable safety profile in terms of hypoglycemia. They will promote weight loss, and they will continue to provide cardiovascular and renal protection. Thank you very much for kind listening.